Hello again, everyone. Assalamu alaikum, and welcome back to another episode of ECREM Talks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I'm your host, Anzal Rehman, and today we're going to be discussing some of the emergency medicine core concepts surrounding salicylate toxicity. Now, salicylates have been around in one form or another for over 3,000 years, useful for their antiplatelet, antipyretic, and analgesic effects. The most well-known drug is acetyl salicylate, also known as aspirin, but salicylates are present in many over-the-counter products and medication, either in a different form or as a combination with other agents. In one form or another, salicylates are readily accessible, used frequently and by most people in the world. Overall prevalence and mortality for salicylate toxicity is relatively low. One study over 11 years in the US found that in 1 million admissions, salicylate toxicity represented just 148 cases, with in-hospital mortality of about 1%. This is good news generally, except that when present, and especially when severe, there is quite a bit of clinical morbidity and physiological sequelae that may result from toxicity. Severe toxicity even lends itself to organ dysfunction and higher mortality rates of around 10%. Identifying and managing salicylate toxicity therefore becomes a vastly important skill for emergency physicians. Academically speaking, there are several physiologic, toxicokinetic, and approach-based considerations that are frequently a part of discussion and examination for toxicology in emergency medicine. So, joining me today to hopefully demystify some of the concepts within salicylate toxicity is Dr. Lara Sulaiman. Dr. Lara is a licensed emergency medicine consultant working at Rashid Hospital in Dubai, as well as a co-founding member of Toxicology Consultation Services at Rashid Hospital. She completed her bachelor's in medicine from the Dubai Medical College in 2010, with an Arab Board in Emergency Medicine training completion in 2015, an additional certification from the European Board in Emergency Medicine in 2016, a membership with the Royal College of Emergency Medicine, that's the MRChem, and finally a postgraduate diploma in medical toxicology from Cardiff University in 2019. For those of you who have not had the pleasure to come across Dr. Lara in Dubai or through one of the various international conferences she has been a speaker at, she works as a teaching and faculty member at Dubai Medical College and the Dubai Health Authority DHA Emergency Medicine Residency Training Program. She maintains a special interest in medical education, open access medical education, and of course, medical toxicology. Dr. Lara, welcome to ECREM Talks.
Thank you, Anzal. Thank you for having me today. And it's my pleasure to be here and share some of nice facts about salicylate toxicity. I hope you will not be bored.
I'm sure we won't be. At least I speak for myself. So before we begin, as always, please make sure to check out our website, ecrem.org, that's ECREM.org, where you can find all ECREM-produced EM educational content, including free open access medical education examination videos, clinical images, and of course, our collection of ECREM Talks podcast episodes. You can also follow us and leave feedback and comments for us on a variety of social media platforms, including Twitter, Instagram, YouTube, iTunes, and Spotify. Now, with further ado, let's dive back into our Core Concept podcast. So before we get started on the bad and the ugly, let's talk briefly about the good with an overview of what salicylates do generally. Drugs like aspirin irreversibly bind and inhibit cyclooxygenase or the COX enzyme. Normally, COX enzymes form prostaglandins, which produce inflammation, fever, and pain. Inhibition of COX, therefore, decreases pain, fever, and inflammation. Additionally, salicylates also inhibit thromboxane A2, preventing platelet aggregation. So, it's a great drug when used for the right reasons. Dr. Lara, what goes wrong during toxicity?
Honestly, asking what does not go wrong might be easier to answer because physiological changes of salicylate toxicity are all over the place. The first effect salicylates have at the respiratory medullary center. Direct stimulation increases the center's sensitivity to pH and partial pressure of CO2, producing the rapid breathing and tachypnea that will lead to respiratory alkalosis, which is the first metabolic or that's the first abnormality that will occur. The body tries to compensate for this alkalosis by buffering through the hemoglobin oxyhemoglobin system, hydrogen ion exchange, and urinary excretion of bicarb. But that kinda will worse what comes next. The primary mechanism of toxicity rears its head when metabolite of salicylic acid uncouples oxidative phosphorylation in the mitochondria, inhibiting the aerobic metabolism. This means we say bye bye to our beloved Krebs cycle and switch to pyruvate and conversion to lactic acid. So we know what means from our DKA, lipid stores break down and form ketones body. ATP is decreased and temperature, metabolic rate, oxygen consumption all will increase. We often get a high anion gap metabolic acidosis as a result, which made worse by the fact that the low pH deionized salicylate, allowing it to cross the blood-brain barrier to enter the central nervous system. Hyperventilation now tries desperately to compensate for the acidosis, but eventually become overwhelmed by the direct CNS toxicity and acidemia. One of the most dangerous phenomena is that either through prolonged elevation of salicylate, respiratory fatigue, ARDS, or effects of co-ingestant, the respiratory center becomes depressed, as well as leading to respiratory acidosis, meaning you now have hypercapnia from inadequate ventilation, CNS dysfunction from the direct action of salicylate toxicity and acidemia in the blood. That's a lot of badness, and it's really, really bad.
Yikes. So basically, we're looking at initial respiratory alkalosis, a mixed acid base picture with metabolic acidosis, and eventually acidosis even from the respiratory side. Now, though what Dr. Lara mentioned is what's primarily going on at the physiologic level, there's a few extra tidbits that warrant mention. To begin with, it's worth talking a little bit about potassium in salicylate toxicity, since it is often overlooked and missed during management. Total potassium stores in the body become depleted through several ways. GI irritation, secondary to ingestion, might lead to vomiting, which depletes potassium as it is exchanged for hydrogen ions. In response to the respiratory alkalosis mentioned by Dr. Lara, an increase in renal excretion of bicarbonate might happen, which also accompanies excretion of sodium and potassium. General renal tubular damage causes more potassium ions to permeate through and get excreted. And finally, the uncoupling of oxidative phosphorylation also inhibits the active transport chain, which worsens potassium loss. Another metabolic aspect of salicylate toxicity worth considering is its effect on glucose homeostasis. Despite glycogenolysis occurring, gluconeogenesis is inhibited. Therefore, though you may encounter normal glycemia in patients, keep an eye out as you could have either hyper or hypoglycemia too from a deranged or unchecked glucose pathway. This is especially important since patients with salicylate toxicity have been evidenced to have a decrease in cerebral glucose concentrations, even when serum levels are normal. This phenomenon, termed neuroglycopenia, rolls off the tongue, doesn't it, is why you need to keep an extra eye out for signs of brain hypoglycemia, like altered mental status or seizures. Okay, so to recap some of these physiological changes, over to Dr. Lara.
All right. So we already mentioned the acid-base progression from respiratory alkalosis, metabolic acidosis, to even respiratory acidosis. GI irritation is well known, like you said, could cause nausea, vomiting, but keep in mind, these can sometimes be so bad that they cause perforation. So something else you need to watch out for. Patient have severe abdominal pain? Rule out perforation. The whole uncoupling of oxidative phosphorylation results in the release of heat and hyperthermia and is classically present, though it's not always the case. So, also, you need to look out for other reasons for hyperthermia. Direct CNS toxicity can happen with salicylate, but you can also have, as you said, neuroglycopenia, as what you mentioned. A few extra areas of injury include ototoxicity, manifested classically as tinnitus, and pulmonary edema can occur, injuries to the kidney that can cause renal failure, and rare cases of hemorrhage from the antiplatelet activity of aspirin.
Okay, so before we begin discussing signs and symptoms, it's important to understand the type of patient you are expecting to see. The vast majority of patients typically present with acute toxicity associated with intentional ingestion. These are usually younger people without any significant medical illness, but the fact that ingestions could be associated with self harm or suicidal intention means you have to consider that salicylates aren't the only substance they've ingested. A huge chunk of patients with acute toxicity are found to have co-ingestions on board, and these typically include things like acetaminophen, opiates, benzodiazepines, and alcohol. History is often tricky because patients do not often reliably report salicylate ingestion, and when they do, you should establish the type of product ingested, as salicylate concentrations between substances varies. Of note, ingestion of just a few ml of oil of wintergreen, quote unquote, often found in some herbal products, equates to more than 5 grams of salicylate. Those unfamiliar with this, which I mentioned in quotes, oil of wintergreen, can relate to products like Tiger Balm or Reparal Gel, more commonly available in our market, which in excess pose similar risk. One other category of patients that's important not to miss are those with chronic salicylate toxicity. And these tend to be older, often elderly patients with multiple comorbidities. These are usually not intentional and occur as a consequence of prolonged use of salicylate containing medication that culminates in an overdose over time, manifesting toxicity at lower doses than in acute cases, but unfortunately with a worse prognosis and a higher mortality for these patients.
So now it's time to talk about how this toxicity looks in a patient and discuss the signs and symptoms of salicylate toxicity. The classic triad of salicylate is made up of hyperventilation, tinnitus, and GI irritation. But as with most classic finding, it's rarely even to be seen in a clinical situation. GI symptoms may or may not be present, but direct irritation of mucosal barriers occurs early in the toxicity and will appear with signs such as nausea and vomiting. Tinnitus is an interesting sign, which may be missed unless the physician directly asks about the symptoms or tests for hearing. Its mechanism isn't entirely understood, but tinnitus also occurs earlier in the course of toxicity and generally tends to be reversible when associated with short term use, while in long term exposure to salicylate, effects may be permanent. In some patients, ototoxicity from salicylate poisoning may even appear as hearing loss in addition to or instead of tinnitus. Worth mentioning is that the hyperventilation is classically associated with tachypnea or elevated respiratory rate. But may not be always the case, as some patients may maintain normal respiratory rate by increasing the tidal volume while they are still hyperventilating. This important symptom may also be overlooked, since it may appear to be due to emotional stress, agitation, and anxiety rather than due to toxicity, especially since it may even be accompanied by tachycardia and diaphoresis. Nevertheless, keep a high index of suspicion for an elevated breathing rate that it's not explained by any obvious respiratory cause. With time, you may encounter the hyperthermia due to uncoupling of oxidative phosphorylation mentioned previously. CNS symptoms such as altered mental status, hallucinations, and seizures may predominate as toxicity progresses, but may actually be the primary sign seen in chronic poisoning. To make matters worse, much of the signs and symptoms mentioned can be confounded or negated by opposing effects of other substances co-ingested with salicylates.
Which makes it all about establishing suspicion with a lower threshold. Salicylate toxicity is hard to detect at times, but patients rapidly deteriorate over hours, and progression to death is likely without adequate intervention. A retrospective study in 2017 by Dr. Shively, I'm not sure if I'm saying the name properly, and her team looked at acute salicylate overdoses over a 5-year period and found that amongst the factors associated with toxicity, by far the strongest predictor of severe outcomes was an elevated respiratory rate, which is crucial to detect in presenting patients. Other risk factors associated with worse prognosis include delays in presentation and diagnosis, increased age, presence of co-ingestion, and altered mental status. Okay, so imagine you have a young patient who comes to your ED with signs of altered mental state after a reported ingestion of multiple aspirin tablets. In addition to, of course, performing your primary and secondary surveys for this patient, investigations would inevitably start with a blood gas, given all the acid base stuff we mentioned earlier. Your classic early finding is a primary respiratory alkalosis followed by a primary metabolic acidosis, usually with an anion gap. If you want to get nerdy, you can use the Winters formula for any metabolic acidosis you see to determine if the PCO2 noted is due to an appropriate compensatory response to the acidosis, or whether something is amiss and perhaps another acid-base disturbance is in play. Long story short, your pH is going to start as alkalemic. The longer and more progressive the toxicity, the more likely it is to find an acidotic pH, and by relation, the more likely it is that the patient is critically ill. While we would expect acid-base derangements to follow the early respiratory alkalosis, then mixed metabolic acidosis in the poisoned patients, we also mentioned that these changes may be confounded by several factors, so they cannot by themselves always confirm the diagnosis of salicylate toxicity. Where suspected, we may then use several additional laboratory tests to evaluate and establish salicylate poisoning in patients.
One of the most definitive tests to confirm salicylate toxicity is, as you would expect and imagine, is the measurement of serum salicylate concentrations. So concentrations between 15 and 30 mg per deciliter are considered therapeutic, and toxicity usually manifests when the concentration exceeds 30 to 40 mg per deciliter. While up to 50 mg per deciliter, patients may experience mild toxicity, such as tinnitus, hyperpnea, or dizziness. While levels between 50 to 70 mg per deciliter usually is associated with more severe symptoms such as fever, altered mental status. Above 75 mg per deciliter is usually when you need to panic and you will encounter seizure, renal failure, hypotension, and dysrhythmias. It's important to note that while serum concentrations tend to correlate with severity, these values do not strictly confer a certain severity purely on the basis of their number, and clinical context need always to be considered and correlated with values obtained. Another important reminder that is chronic toxicity can have significant clinical manifestations at levels as low as 30 to 40 mg per deciliter.
Interesting. So what you're saying is the level won't always correlate with severity of symptoms. So an obvious question then to ask is, why do the level in the first place?
Well, that's a good question. While it may be anticlimactic to mention values and then say symptoms may not always match the numbers, these ranges give an approximate of what you tend to see. What's important, aside from the specific number, is the elevation in the concentration itself. This will allow you for a specific measurement and to be established that toxicity present in suspected individual. In addition, for patients undergoing treatment, you can use this cycle of these concentrations every 2 hours or based on your local institution protocol to monitor the response of therapy or progression of toxicity. Of course, during this time, you always should repeat your blood gases and other measurements.
So, we mentioned a blood gas, we mentioned serum salicylate concentration, but what about the other investigative modalities you should use in patients with suspected toxicity?
Well, to start with, your standard metabolic panel would give you an idea about anion gap, though be careful with chloride, since it could be falsely elevated with salicylate overdose. Other important measurement would include the potassium level to check for hypokalemia that can be a result from severe acidosis. Also included will be the creatinine level to assess any acute kidney injury. So we mentioned how patients could have altered mental status. So it would be a good idea to measure blood glucose, CBC, liver enzymes, and other electrolytes like magnesium, phosphate, and definitely include acetaminophen and blood alcohol levels, as co-ingestions happened. In case we haven't drilled that in your head by now by repetition. A lot of these patients may end up getting CT for altered mental status to evaluate other causes. And it really depends on your clinical examination and a clinical picture. A chest x ray for pulmonary edema may be needed, especially if your clinical signs suggest this.
Okay, let's talk management specifics. You have a patient come in with a suspected intoxication, let's say. So you would proceed first, as you do, with an initial primary survey of airway, breathing, and circulation, our famous ABCs. Attach the patient to a cardiac monitor, get an IV line in, and provide supplemental oxygen if hypoxic. An important point to note before we speak about the other aspects of care is regarding intubation, since we mentioned airway. For patients with salicylate toxicity, we generally avoid intubation as much as we can. This is because the apneic time peri-intubation can be disastrous for patients who were using tachypnea to blow off all that carbon dioxide with respiratory alkalosis. Take that away and you have hypoventilation, hypercapnia, and consequently worsening acidosis and a dangerous predisposition to death. So try to avoid or delay where you can. Using high-flow nasal cannula may help reduce work of breathing for some patients. If a patient can't protect their airway, already have hypercapnia or worsening acidosis despite therapy, severe hypoxia, or status epilepticus, intubation may be your only option. In which case, where possible, try for awake intubation to reduce apneic time. And maybe give sodium bicarbonate bolus doses of 1 to 2 milliequivalents per kg pre-intubation. Insertion needs to be fast, so defer to the most experienced staff member available. No time for heroics. Once inserted, attach to the ventilator, which needs to match the patient's high respiratory rate to mitigate acidosis. Use high tidal volumes of approximately 8 to 10 ml per kg and keep your respiratory rate high with regular blood gas measurements to gauge control over the acidosis. And also keep the PCO2 below 20 mm per mercury if possible.
While you're tending to your A's and B's, when evaluating circulation, it's important to keep in mind that patients with salicylate toxicity are often volume depleted. There is a considerable degree of fluid loss from all the increased respiration, work of breathing, fever, GI irritation, and insensible loss from increased metabolic activity. Watch out for pulmonary edema if present, but generally these patients require early aggressive fluid resuscitation to account for this loss. If hypotension is present and unresponsive to fluids, consider adding a vasopressor to assist hemodynamics. Make sure you are checking and accounting for hypoglycemia, remembering that neuroglycopenia we mentioned earlier may be in play despite normal serum glucose levels, especially in altered mental status. When patients present within 2 hours of ingestion, it may be reasonable to administer activated charcoal at a dose of 1 gram per kg up to 50 grams, provided that the patient's mental status allow them to tolerate oral intake and avoid risk of aspiration. The risk of aspiration should be low in these patients. You may not be able to give them, and because they are not able to maintain their oral airway or they have protracted vomited. And then you need to be worried about aspiration. If a patient is intubated, then you may put an NG tube or orogastric tube and administer charcoal. As far as decontamination goes, charcoal is your best bet, as lavage, induction of emesis, and whole bowel irrigation are seldom useful. Though remember that whole bowel irrigation may be considered while extreme caution and discussion with your toxicologist in cases of large amount of tablet ingestion.
I think that's a good segue into another important consideration, which is always, always, always call your local poison control center or toxicologist early. When you're making that call, maybe talk to your nephrologist as well to preempt what comes next, aka the potential hemodialysis. But we'll get to that in a bit.
So, we talked about resuscitating patients with toxicity, mentioned decontamination, and now it's time to move on to elimination. Unfortunately, while there is no antidote to salicylate poisoning, we do have effective treatment options that will assist in the elimination and excretion of the drug from the body. The goal of enhanced elimination is to prevent entry of circulating salicylates into the tissue, especially when it comes to the brain, as well as it will accelerate the excretion through the urine. The way this is achieved is through serum and urine alkalinization, and it's useful for all symptomatic patients with salicylate poisoning, especially those with moderate to severe symptoms. So how does alkalinization work? To put it simply, salicylate exists in the body in unassociated form, and it tends to move to the compartment where the pH is higher. Unfortunately, when an acidotic environment exists extracellularly due to the metabolic acidosis that accompanies the poisoning, all that salicylate gets driven into the tissues and manifesting as worsening end organ damage in those regions. When you alkalinize the serum and urine, you increase the extracellular pH, which moves salicylate out of the cell, or at least prevent penetration it into tissues. And to enhance this even further, the increased urine pH causes salicylate to move from the plasma to urine, converting it into ionized form, which cannot be reabsorbed into the renal tubules, so becomes trapped and rapidly excreted with urine. Hence, the higher pH serum and urine directly corresponds to how quickly we can decrease the salicylate level. The target serum pH is 7.45 to 7.55, whereas the target urinary pH is 7.5 to 8.5. The standard way this can be achieved is using an initial bolus of IV sodium bicarb of 1 to 2 milliequivalent per kg over 1 to 2 minutes pushed, followed by an infusion which is usually made up of 3 ampoules. That's 150 milliequivalent sodium bicarb in 1 liter of D5 water. Do not use normal saline for infusions because with the added sodium bicarb, that's a hypertonic cocktail you don't want to mess with. The infusion, however, allows you to then sprinkle in potassium replacement, typically 40 milliequivalent of potassium chloride, to address the hypokalemia from acidosis. That should preferably be corrected up to the target of 5.5. Insert a Foley's catheter and titrate that infusion to target serum and urine pH with adequate urine output of 1 to 2 ml per kg per hour.
Now, I know you guys are thinking that sounds like such an intricate setup, but it's actually rather easy to do. And the whole thing makes a lot more sense if you consider the physiologic changes happening and target your therapy to counter on all fronts. I say this and I can almost hear the imaginary cheers from my fellow EM residents who just love their physiology like I do. On a serious note, apologies to those who have had to suffer me droning about this in person. Hopefully, though, our discussion today has made some of the details more palatable. Anyways, moving on. We have one last thing to touch on before we wrap up management of salicylate toxicity, and that is the end of the line option, hemodialysis. If the patient is unresponsive to therapy, has renal failure and cannot excrete urine, has end organ damage or worsening acidosis, or poor hemodynamic status despite aggressive therapy, start hemodialysis. Better yet, if you are uncertain about eligibility for hemodialysis but have a patient who looks sick, call your nephrologist and ask for his input. General indications for dialysis include significantly altered mental status, seizures, pulmonary edema, inability to tolerate sodium bicarbonate infusions, coagulopathies, worsening or refractory acidosis or hypoxemia, and initial salicylate levels exceeding 100 milligrams per deciliter. If hemodialysis is indicated, it works best if initiated early to prevent further end organ damage and reduce morbidity. So, all the more reason to get on that phone early if you're unsure. All symptomatic patients are admitted, and those with significant signs of toxicity go to the ICU. As mentioned earlier, cycle your salicylate concentration every 2 hours until levels fall below the toxic range. Then monitor every 4 to 6 hours with electrolytes as per the clinical picture. Whew, that was a big one. But we made it. Thanks for sticking around, everyone. Dr. Lara will now go through the core concepts of salicylate toxicity.
Thank you, Anzal. So, salicylates are readily available and frequently used by many patients. Consider intentional ingestions in acute toxicity, usually in younger patients, and unintentional gradual overdose in chronic toxicity, which is usually in elderly individuals. Salicylates act by causing early respiratory alkalosis, a primary anion gap metabolic acidosis, if unchecked, a disastrous mix of respiratory and metabolic acidosis. Acidosis may cause hypokalemia, GI irritation, and it causes nausea and vomiting, and CNS symptoms happen from direct toxicity. Consider neuroglycopenia or relative glucose deficiency in the CNS when salicylates are on board, and keep an eye out for hyperthermia. Remember that an elevated respiratory rate is strongly linked to severe outcomes, so learn to recognize it within the context of an intoxicated patient. Establish and confirm diagnosis with blood gas and serum salicylate concentration, but do not forget to check for electrolyte derangement, acetaminophen level, alcohol levels, and co-ingestions, because co-ingestions are common. When managing patients with toxicity, prioritize your ABCs always. Aggressively fluid resuscitate to account for the losses. Avoid or delay intubation when possible to prevent hypercapnia during apneic time worsening acidosis. Remember, call your toxicologist and nephrologist as early as possible. Early decontamination with activated charcoal may be useful. Enhanced elimination uses serum and urinary alkalization with IV sodium bicarb to more rapidly excrete out salicylate and prevent tissue absorption. And remember to target your serum pH 7.45 to 7.55 and target your urine pH to 7.5 and 8.5. Where therapy fails or end organ damage is significant, consider hemodialysis.
That concludes our episode on salicylate toxicity and our brief overview of its core concepts. I have to say, it was an incredible honor to break down this topic with you, Dr. Lara, and provide what I can pretty confidently say is a rather comprehensive review of all its aspects. We are very happy to have you on board with us at ECREM Talks and hope to see you soon for future sessions.
Thank you, Anzal. It's been a pleasure to be here, and I hope we can meet in further collaborations, inshallah, next time.
Inshallah. Thank you once again for joining us, and thank you to Rashid behind the scenes quietly watching and waiting in the shadows. Thank you to our audience again for joining us on ECREM Talks. We hope to catch you for our next episode very soon. Don't forget to check out all ECREM content on ecrem.org and visit our social media accounts through the links in the description. Until next time, this is ECREM Talks, signing off.